Hello and welcome to the ESRS Forum panel discussion on refractive IOLs. I'm your host, Dr. Rudy Neitz, and today I'm joined by Dr. Thomas Koenen and Dr. Doug Koch. Welcome, Doug. Welcome, Thomas. Today we will discuss the keys to surgical success in astigmatism and presbyopia correction with cataract patients. We aim to explain the available presbyopia and astigmatism IOL treatment options and their ideal patient candidates. We will also discuss the importance of acquiring precise preoperative measurements as well as the necessary steps to take intraoperatively and postoperatively to ensure good visual acuity, quality, and patient satisfaction. A review of the 2018 ESRS clinical survey revealed that 7% of cataract procedures involve presbyopia correcting IOLs. Overall patient satisfaction for near, intermediate, and distance vision was higher in presbyopia correcting IOL patients when compared to patients with monovision. How do you decide, Doug, on which patients receive monovision IOL correction versus getting presbyopia correcting IOLs?
Thanks, Rudy. I like monovision, particularly in patients who've already done it with contact lens wear, because those patients have demonstrated that that's a very workable solution for them. They function well, they accommodate well to it. I will also employ monovision in patients I don't think are otherwise a candidate for a multifocal or presbyopia correcting IOL. And the way I do that typically is to do the distance eye first, and if they have great vision and they're happy with it and they function well with it, then I feel like I can take the liberty of giving them some near vision in the fellow eye. But my indications for monovision are clearly diminishing as the quality of our presbyopia correcting IOLs improve.
And you, Thomas, what's your strategy there?
I think Doug just pointed out. I have used in the same instances like he just pointed out, but with the new presbyopia correcting IOLs, particularly with trifocal intraocular lens, the numbers for me have totally decreased, very much.
Are there any particular tips that you have for the selection in the patient that don't have access to the patient group where we had preoperative contact lens wear, Doug?
If they have mild cataracts, you can do contact lens fitting. But other than that, like I said, I like to do the distance eye, and if I nail it, they're happy, they love their vision, and I'll ask them, are you comfortable with your vision? Can you function fully in your distance world? Okay. And if they can, then I feel like I have the luxury of making that eye a near eye. But if they tell me, this other eye is still bothering me, I'm happy with my new eye, but I'm not happy with the other eye, that tells me they're probably not going to neuroadapt to monovision.
That's a big story, because if you do this, then I think you always have to do one thing. You do first a surgery, you wait, see the patients again, then you do the second eye surgery. Okay. Now, in our country, at least with me, we have come down to a very narrow window now where we do the procedures, and then you really don't have the time. So therefore, the presbyopia correcting IOL, I have an advantage in this. That doesn't mean that you already have the outcome already, but this, what you just pointed out, takes a little more time.
Okay. Overall, what type of patients should not receive any of the various presbyopia correcting options in order to maximize individual outcome to the patient, Thomas?
We have to cover then the whole range of presbyopia correcting IOLs, and I would like to grade them in the current multifocal, the trifocal lenses, and the EDOF lenses, also presbyopia correcting IOL. But I'm a little bit hesitant to put them in if the patient do not require, let's say, to be less dependent on reading glasses. Or if they don't care, then I think I give them a real good monofocal lens for distance visual acuity. That's maybe a good option, So I don't force them into this presbyopia correcting IOLs, because we still have some visual disturbances, and we have to adjust that, and have to discuss this with our patients.
Okay. What's your position on that, Doc?
Yeah, I really agree with Tom on that. The ones that I'm really worried about are those patients who are myopes. The -3 myope who's been spectacle independent for near their entire lives. And as good as our presbyopia correcting IOLs are, they don't give you the near vision quality that those patients are used to, and they can be really disappointed. And I warn them that the quality of near vision will be not the same, and very often they will elect to retain their myopia, and they're very happy. They can see the computer, they can read, and they're very used to putting on glasses for distance. Otherwise, it's the truck driver who drives at night, the athlete who has to have perfect distance vision at all times and doesn't want any kind of dysphotopsias. There are certain patients for whom clearly bilateral great distance vision is the better choice.
What do you do in a patient that had previous refractive laser surgery?
Those are tough. I like three options. I like monofocal IOLs. I will occasionally do some monovision in those patients. I will occasionally use an EDOF lens. Some of the quality of vision with some of the multifocals is getting better, and if the topography looks really regular, I might consider that. I'm also intrigued, frankly, by the IC8, which we don't have FDA approved yet in the United States, but to me that's a really nice option for the non-dominant eye to give them a greater range of vision and not have the concern about inducing new aberrations.
You, Thomas, do you have a particular preference in patients with previous refractive laser surgery, choosing a presbyopia correcting IOL?
Yes, I agree with what Doug said again, but I think we have to differentiate between laser surgeries. I mean, the low myopes, the low hyperopes, where they come from 1 to 3 diopters, maybe not so critical, but the higher corrections, and particularly what you pointed out in the topography, so if they have a very flat cornea or higher order aberration, so you do ocular aberration measurement might be very useful. So I also tend more to monofocal lenses, but I also now more and more go in the EDOF lenses. Okay. And particularly because we have, on top of the diffractive, we also have non-diffractive in Europe. And that is a good option for them because the visual disturbances come. But I think we have to really study more on this, and it's a very important topic. Doing the IOL calculation correct, and then have the right IOL. So that's for the future really good.
In the patients who have kind of a dry eye, I would say moderate dry eye, what do you do there?
Well, I think that the dry eye is very important for everybody who starts with this or is doing it to take first of all care of the preoperative examination. We all know that, particularly let's start with trifocal lenses. Trifocal lenses, you have to make the patients ametropic, almost ametropic, and therefore the measurements come even more important. So if I see dry eye in my preoperative examination, then we have to pre-treat them and do another examination, maybe 6 days, 7 days later, pre-treat the eye, and then take several measurements till the measurements are very consistent. But I don't think that with this moderate dry eye, they are exclusion. This is an exclusion criteria for trifocal intraocular lenses.
Doc, I mean, you only got recent access, I think, to trifocal in the States, is that correct?
We just now have them.
Yeah. So do you think it makes a difference which type of presbyopia correcting IOL you use in moderate dry eye patients?
Yeah, I think it does, Rudy. To my management of dry eye and EDOFs and multifocals is that we get a placido image on our patients the first visit, and if that's a clean, clear image, and I look at the surface, it looks good, and the tear meniscus is good, I know I'm in good shape. But if I start to see evidence of dry eye, be it staining, poor Meyers, whatever, I treat them sort of at one level, which would be tears, warm compresses, omega-3s orally, and maybe some lid scrubs. And if that gets them in good shape, a good healthy surface, then I'm comfortable. But if it takes all of that in 2 drops and plasma tears or whatever it is, if it takes a lot to get the dry eye in great shape to get good measurements, to me that then kind of rules that patient out, because that would then mandate that patient go full out post-operatively in order to maintain quality of vision.
That's clearly a contraindication, what you just described. We should be very careful in these patients because they're demanding maybe, and we give them presbyopia correcting IOL, we promise them something without glasses, and if we cannot achieve it, then patients are not happy.
Yep.